Bonjour mesdames et messieurs, ce matin, comme c'est samedi, tout se passe en français et nos interprètes vont interpréter en anglais. No. Just a joke. Sorry. Good morning, ladies and gentlemen. Thank you for being here so early on a Saturday morning, especially after what was a wonderful dinner in the Eiffel Tower. Today, we're going to talk to you about a very practical course in implementation tools for the early detection of cerebral palsy. I have the privilege of having with me two other presenters who will take over at various points. We have Dr. Andrea Duncan from now CHOP, the Children's Hospital in Philadelphia, a neonatologist, and one of our lead investigators in the network I'll tell you about. We also have Ms. Rachel Byrne, who is the Vice President of Projects at the Cerebral Palsy Foundation, and who was one of our leaders in this enterprise. So we're going to start and just tell you what our goals are for today. We'd like you to understand, for those of you who do not already know, what the building blocks are for early detection of cerebral palsy. We're going to do a short exercise so you can identify in your own setting what you currently have and what you wish you had. Then we're going to determine what obstacles or challenges you might face and what possible solutions would work for you in your settings to implement guidelines for early detection of cerebral palsy. And finally, we're going to map out what the change would look like for you and your team. First, most of the tools that we're going to be using and recommending are from a landmark article in JAMA Pediatrics that talked about the international guidelines for early detection. These represented a systematic review of the evidence, as well as a consensus of multidisciplinary experts, clinicians, and researchers, as well as parent and community stakeholders. They all agreed that early detection of cerebral palsy should occur because it allows for optimal developmental trajectories for children and mainly also best outcomes for parents. So why do this? We're trying to address a very common gap in practice. It can take between 3 and 28 years with an average of 17 years between the time new research is published and the time that it is actually implemented into clinical practice. And I actually looked at this article by Dr. Morris from 2011 that actually showed that it can take up to 128 years sometimes for best evidence to be implemented into practice. This is absolutely unconscionable. It's outrageous when you think that plasticity of the human brain is at its peak in the first 3 years of life. This means if we wait 17 years to implement into practice, a child born today whom we know could have CP would not benefit from this. So it is a responsibility for us all to see to what extent we can diagnose early. But what I will show you is that this should happen in a way that is unique to your setting, your values, and your capacity. I can tell you that implementation of a single guideline tool, let's say it's the Hammersmith Infant Neurological Exam, can happen within the course of 2 months in your setting if you decide to do so. We've done it. Implementation of the entire guideline set in one setting can be accomplished in 12 months. And what we decided to do is to accomplish this, use a stepwise implementation process. I'm not sure how many of you are familiar with this PDCA approach. It stands for Plan, Do, Check, and Act. a simple cycle that's used in a lot of quality improvement science. The only part that we're going to do here today is the plan, not the other parts of the cycle. And what we did is that we were able to do this kind of process across a network, and I'll show you a little bit what happened, of 5 institutions who all had follow-up programs for infants who were at high risk for developmental problems. We planned for 3 months, and then we implemented, consolidated, and developed new ideas. The results of implementing the guidelines across a network that I mentioned yesterday covers 13% of the American territory, 38 million people, and about, I believe, something like 50,000 kilometers squared. Oh, more than that, 500,000. Sorry about my math. Was this. We had an aim to decrease the age at diagnosis of cerebral palsy to be at 12 months. We thought that was a solid goal across 5 hospitals. And using the implementation science methods I mentioned earlier, we were actually able to decrease the weighted average age at diagnosis throughout our network to 9.5 months. We did not expect to do better than what we had set out to do. What we found out through the PDCA process, and another process we're going to talk to you about, which is borrowed from business, Lean Six Sigma methodology, is that there were visits that were absolutely critical to implementing the guidelines. And that visit was a 3 to 4 month visit. We're going to talk about it during some of the workshops that you have. That 3 to 4 month visit with a general movements assessment, GMA, and with a Hein, Hammersmith Infant Neurological Exam, as well as a motor assessment of your choice, allowed us to achieve these results. So we knew that that increase in 3 to 4 month visits would be critical to implementing these guidelines, which is why we used it as a metric of success. Finally, what we saw is that implementing this process did not change the overall number of diagnoses at the site. It simply brought down the age at which they were diagnosed. Very importantly, when we implement change and the guidelines, we need to make sure we have what's called balancing measures. For all of our sites, we had 2 balancing measures. One of them was a measure of efficiency of the clinics. What if we implemented these guidelines and our clinics were less efficient? We used no-show rates, and I don't have it here, but I can tell you that there was absolutely no change in the show rates in clinic. The templates were used just as efficiently as they ever were. We also asked 3 months after the diagnosis how parents felt about that initial visit where they got the diagnosis. And we asked them questions that always started with, how much did the provider do something? By and large, they had very positive responses. They thought that the providers showed warmth, respect, was honest, direct. The one thing that we thought was an opportunity for improvement was that we were not somehow giving enough information about the diagnosis and in words that they could understand. This is very important in the US. I don't know if it is in your settings. In parts of Ohio where I live now, up to 30% of the population in some areas is illiterate. So how we approach the diagnosis in these people, in this population, is very important. So what are the elements of the guidelines that we implemented? The systematic review talks about standardized elements for detection in 2 pathways. One for infants who present to you in your setting at less than 5 months of corrected age, and then the others at more than 5 months. The reason why we use corrected age is because up to 40% of children who have cerebral palsy are actually preterm. What you can see in dark purple are the elements that have the highest level of evidence, and in pink, the ones who have moderate to low quality evidence. In the less than 5 months of corrected age, you can see that the Hein, MRI, and general movements assessments are the highest. In the more than 5 months corrected age, almost everything is in the pink, but we have the Hein, MRI, the Ames, and then, so that's the Albert Infant Motor Scale. And then the DAISY is the one with the highest evidence. The DAISY is actually development assessment of young children. It is a questionnaire-based assessment of developmental milestones. It is asked of parents and confirmed by the provider. So we talk about these guidelines, and we talk about how we should implement them to the best of our ability. It's very important, even when we look at assessments and at these elements, that we realize the difference between an ideal implementation and what reality actually is. Not everyone can have the general movements assessment. It's accurate, but sometimes expensive or takes too much time for certain settings. So it's always important to think, if I couldn't do this, what could I do? So the things that you can look at in the reality of things is, as you see these young patients go through your medical settings or even community settings, what is the age at which you see your patients? What types of neurological exams do you use? What types of standardized assessments, and are they actually standardized in your settings? What does your team of multidisciplinary providers look like, or is it just you? And do keep in mind reimbursements. Now, not everyone has a healthcare system where everything is reimbursed. We deal with a system in which only a portion of it is, and so we have to be very, very conscious of responsible use of our resources, our time, our people, our assessments, our space. So going back to those elements, what you'll see, we'll give you handouts. You'll see guideline elements, and you'll see that for all of them, we've put level A and level B, option A, option B. What outcome are you trying to measure out of a guideline element? And level A means you are looking for all the elements of the guidelines are met and the parent is in a receptive situation. And level B would be the parent is not receptive, or all the guideline elements are met, but there's a high degree of uncertainty and the parent is unreceptive. So there are lots of different situations when you're giving the diagnosis. Also, when you look at biomarkers such as the general movements assessment or head ultrasounds or other markers, there's always a plan A and a plan B. Plan A is what the guidelines would say you need to do, and then plan B is, right now, I can't do what the guidelines say, but this is another good option. So an example of this is the general movements assessment. We could use this in the NICU, and we could look for cramp synchronized patterns. If you're doing the Practals general movements assessment and you find cramp synchronized patterns in the NICU, we know, based on the review by Kwong et al. In DMCN last year, that they have high specificity, a little bit lower sensitivity for movement disorders later on. So this is a start. But what if you don't have certified providers in the GMA? What if you don't have a team of them? What if you don't have an MRI? And what if you don't have anyone to counsel people in the NICU? What could you do? So that would be option B. Perhaps you could send a video of the baby moving to someone who is certified in the general movements assessment. Perhaps a team of reviewers could meet now and then to calibrate and go over videos. If there was only one person who could do it, you could have Zoom meetings to discuss it. And what if you can't get an MRI? Well, sometimes it's not possible in your particular setting, even though it is recommended. So there's a lot of things that sometimes you can't do. So what do? You do the next best thing. And that might be seeing that child at 3 to 4 months. For neuroimaging, there are similarly different options. Sometimes you will only be able to do a cranial ultrasound. Your setting is such that that's what happens. We can still get some information from that. And if we talk about others, the Hammersmith Infant Neurological Exam is a good example of a test that, while it is not the first line, is still a very good assessment that you can start at 3 to 4 months. It's free. You can get trained fairly easily. Dr. Cohen and Hadisha have put up wonderful videos for people to learn how to do it on their website. And as a team, you can all do it, no matter what your provider level is. This is good for anyone from a nurse practitioner to a neurologist. If we look at motor function assessments, the guidelines in that pathway talk about the TIMP, the Test of Infant Motor Performance. If you did not have a physical therapist who could do a TIMP, you could have one trained. It turns out that there are video trainings for this assessment, and physical therapists are so used to handling babies that they can learn this with very little time. Let's say you don't have a therapist. You could still use the AIMS. The AIMS is accessible to other providers in a way that the TIMS sometimes is not. For every element of the guideline, sometimes in your setting, you might say to yourself, I can't do this, but I could do the next best thing. And that's what we're going to talk about. Be realistic, and as we look through this list, what we would like you to do is to say, I have this, or I don't have this, first. And then, after that, if I don't have this, what could I feasibly do? And we'll go around and we'll help you with this. If you have something that you don't have, but that you would like, we might be able to help, especially with some of the more creative solutions. So right now, identify the tools you currently use out of this spreadsheet that you were given, and the ones that you would like to have. And let's talk. All right, so we're going to circulate, and raise your hand if you want us to come. We'll be right there.
How do we... So what you'll see in your handouts is at the beginning, it actually has the category, then timing, and then the guideline element. So really thinking about where you are within your clinical setting or research setting, are you seeing children less than 5 months corrected age, or are they over 5 months corrected age? So if you have a look, you'll have category, timing, guideline element. These are sort of your core things that you need to be looking at right now. And within the timing, it goes NICU, which you'll see 3 to 4 months, corrected age, and then you'll have greater than 5 months. So if you're just thinking along these two different columns, you can start circling which ones you currently use. And that should just help you in that guideline element.
But we need our therapists to inform us about function. And that's what they do. So the motor function assessments are critical. Oh boy. So I was talking about 5 elements to make a diagnosis. I said clinical history, neurological exam, neuroimaging, tests of motor function, biomarkers such as the general movements assessment or cutoff score on a test, and then finally, there's always the last part that's not part of the diagnosis, but it's excluding everything else. So excluding genetic and metabolic problems. So the reason for those elements is that they are all part of that 5-part panel that lets us make the diagnosis. What would you like to do? Okay, sure. All right, so I think by now all of you have had time to sort of look at what the elements of the guidelines are, what option A, which would be the best possible thing, and many of you, I'm absolutely pleased to see, already have things like the general movements or the test of infant motor performance, and some of you are just missing the Hammersmith. The Hammersmith, there are, in addition to the videos, some trainings that can be obtained, and if any of you are interested, please contact us. They're free. The Hammersmith was designed by Dr. Lily Dubowitz, is in the care of Dr. Francis Cohn and Dr. Lina Hacha, who respect her wishes and want to make sure that this is an assessment, a neurological exam that is freely available to everyone at every level of practice, therapist, medical provider, it doesn't matter. So please talk to us if you are interested.
So I think now we'll sort of be moving on to different other tools that you can use within the implementation science research process. And I think, you know, when we look at what you've just all done, you know, I was just speaking with somebody who was like, I'm actually not using anything. You know, where do I even start? And sometimes that can feel quite overwhelming. But what I would do is I'd go, okay, well, when do I see children? I might see them at 3 to 4 months, but not really. Maybe they're starting at 6 months, 9 months, 12 months. What are you currently doing? Well, if all you're currently doing is a clinical examination or, you know, a basic developmental test, then that's what you write down to start with, and then we start building on it. The whole point of implementation science is really that you're using building blocks to develop a plan by the end. So another really good tool that you can use is called a SWOT analysis. So that's strengths, weaknesses, opportunities, and threats. And really it's a strategic planning technique to help identify what's related to your project planning. So if you're thinking about the strengths, you know, what characteristics of your team give it an advantage in implementing early detection in CP? Do you currently have resources? Do you currently have just people that are very interested in obviously implementing this at an early age? Do you have people that are trained in all these different elements but not actually utilising them? So weaknesses, characteristics of your team that place it at a disadvantage in relation to the guidelines. So both strengths and weaknesses are internal to your team. Opportunities, so opportunities about elements in the environment that you could exploit to your advantage. And threats are elements in the environment that cause trouble for the project. And I think it's always important whenever you're trying to embark on any sort of project to try and identify these from the beginning. So for example, this is what it looks like a SWOT in the healthcare system. So again, remembering that strengths and weaknesses are internal. So if we're thinking about what is the strength and helpful to your end objective, as I said, it could be outstanding medical staff, a strong commitment to the community mission, excellent hospital or institutional facilities, outstanding healthcare quality, and high level of organisational efficiency. Weaknesses that you could think of that could be within your internal environment are lack of adequate resources, lack of primary care network, and shortages of critical staff. If you're then going to think external to your environment, what opportunities could be in the broader community? So for example, it could be that the community in itself is growing. You might have an increased managed care business or growing community healthcare programs. Threats could be reduced government reimbursement or decreased insurance, competition for specialty physicians, and increased competition from healthcare provider networks. So this is an example of what was done at Nationwide Children's Hospital before they actually even began this whole process. So strengths that they really saw as an institution was to market capture neonatal paediatric is good in a 200-mile radius. So that's really good. You're actually already starting to define what area are we looking at here when I'm going to start implementation. The size of the NICU is actually large. That means that you've probably got a lot of resources and trained staff. Collaboration with the Research Institute already exists. The Neonatal Research Network, which is a network in the United States, supports research and highly standardised and reliable assessments at 2 years of age. So because they're already part of this network, they were already used to implementing standardised assessments. And I think this is a big one in the fact, particularly when you're looking at the guidelines, it's recommending using standardised assessments because that's where the best evidence lies. An accountable care organisation. They had lots of different human resources, and this is definitely not the same for all settings. Nationwide Children's Hospital is a very large hospital in the United States. They had nutritionists, social workers, PTs, OTs, subspecialty and general providers, nurses, schedulers, and those that did the intake. Now, sometimes big is good, and sometimes big can be very bad. Depending on where you're at, you might not see that as a strength, it could actually be a weakness. Space for clinical and developmental testing rooms, provide a workroom in place. Care coordination already exists in different programs for high-risk infants. Evidence-based coordinators exist in the clinical therapy department, and state early intervention programs have been established for referral pathways, because obviously, you know, why we're all here is early detection matters, but we really want to make sure that then early intervention and the right pathway is set forward for these children and families. The weaknesses though, you know, and this one's a little bit when you're thinking about if you've got a really large team, sometimes it's hard to have efficiency in staffing utilisation. The evidence base is lacking at some ages for some assessments. Lack of follow-up at 3 affects transition to school programs. No-show rates are high at 3 to 4 months. You know, so what are you going to do about that? Because we know this 3 to 4 month assessment, according to the guidelines, is a really important time point to get some information. The current age of cerebral palsy diagnosis is actually unknown. So when you're ever going to do any sort of implementation science, you really want to get your baseline measures. And sometimes you can't get them because you didn't have a system in place to collect that data. No speech-language pathology involvement below 18 months. Limited research experience in the clinic. So wonderful clinicians, but not so good at potentially, or not so experienced at looking at research methodology. Lack of knowledge base in early CP assessments and effective interventions. There was also a lack of knowledge of therapist scope of practice and available programs at the institution. And they weren't using the same forms and notes for clinical documentation in their electronic medical records. And I think we've all come across this in multiple times in the fact that, you know, how do you actually collect good data if everybody's using different systems? Opportunities though. You know, the strategic plan for Nationwide Children's Hospital came out, and the journey to best. It was defined as not only what happens at the point of acute care, but also the periods between and after care when a child has better health because of the services that are provided. So the really great thing is that actually the early detection guidelines fit exactly into their strategic plan. So then to get buy-in for administration staff was a lot, not easy, but at least there was a point of conversation that could start. Early CP guidelines were established at the Impact for CP Summit, and then as we discussed, were published in 2017. Congenital heart defect guidelines by the American Heart Association emphasise importance of broad neurodevelopmental follow-up. Neurodevelopment outcomes are of great importance in neonatology as a quality of care outcomes. And there was a network of 9 NICUs in Ohio, always allows dissemination of knowledge and practices, because obviously you want to sort of try and think about this like a stepwise approach. Okay, you don't have to do everything at once, but what's going to be next? You might do it in your setting. You might go, okay, we have a relationship with the setting down the road. We're now going to spread it to there. The EPIC platform development is ongoing. So EPIC, as I said, is an electronic medical record. It allows for standardised input and also actually allows for a lot easier data collection in some elements. New research studies are funded, emphasising rehabilitation, which is exciting because, as I said, early detection leads to early intervention. And a comprehensive CP program already exists and is directed by a specialist in complex care and internal medicine. Threats. This is a big one. Sustainability, return on investment. You know, sometimes you could think, oh, right, this is a very costly process. You know, how am I going to actually show that there is sustainability in this, that this isn't just a black hole in the budget? And home-based program offerings at other institutions. As we said, competition can actually be a threat. And so, you know, if you've got home-based programs at other institutions, people have a choice where they go. So now what you'll see, and I'm just going to take you through what looks like, you know, how you might actually start planning out a SWOT analysis at your particular location. So for example, you know, the aim would be we will implement best practices for early recognition of CP by sustainably adapting our existing resources and supplementing them with knowledge, training and infrastructure. We do this because we strive for the best outcomes for infants for CP. So that's very much like your mission statement, your vision statement. As I said, whenever you're looking at doing any sort of implementation process, what are your endpoints? So, as I said, as Nathalie mentioned, across our network, some of the pieces that we had was, all right, we want to get the age of diagnosis down to 12 months because we were currently at around sitting between 19 to 24 months in the US. So, what do you think is realistic for your setting? What aim are you going to put out there as far as an endpoint? And then what tools do you think you're going to implement? You just identified the tools that you're currently using. Which ones do you now think that you will use as your screening tools? For example, they were using the GMA as a screening tool in the NICU and then also using the GMA at 3 to 4 months. They then added the Hein at 3 to 4 months and then a follow-up at 9 to 12 months. Really important to get those data collection and metrics in place. Then it's to think about, all right, what would be helpful to my process? If I'm going to show anyone that you're going to get a good return on investment here, it's not essential, but what other metrics might I want to see? So for our network, the total visits in clinic, less than 12 months, at 0 to 2, 3 to 4, and 5 to 12 months were really important to collect. How many of these children are actually preterm and what's the percentage? The individual CP diagnosis in clinic in that 12-month period, how many are we actually getting? The visits less than 12 months in clinic with the CP diagnosis. The average age of that diagnosis that patients are. And the total number of patients with the diagnosis CP under 3 years at your institution. So as Nathalie mentioned, that didn't actually increase across the network. Yes, the age was brought down, but the number of patients getting diagnosed did not change. So this is when you come to your SWOT. So what are you going to do? What are the strengths that are internal to your particular institution and what are the weaknesses? Here are, and I'm sorry that it's a little small and I hope everyone can read it, but here are sort of some questions and guiding elements for you to start writing down. So if we're thinking about strengths, think about what are the basic elements of the guidelines that you already have. So we've already started that process. What do we do better than anyone else? What do people see as our strengths? What expert or specialised skills do we have in addition to those recommended in the guidelines? What factors mean that we have best outcomes for infants with CP? What factors mean that our patients return and find value in our programs? What current externally funded studies do we have to inform diagnosis or prognosis of CP? In the weaknesses, so internal weaknesses, what could be improved? What should we avoid? What are people likely to see as weaknesses? Where do we need additional training or education? What factors mean we don't have the best outcomes for infants with CP? What factors mean that our patients don't return or don't find value in our program? Where do we need additional infrastructure? And when might we need partner with other professions? If you're thinking about your opportunities, so these are external, what good opportunities can we see? What interesting trends? How can we better meet the needs of our patients? What current changes in technology and markets on both a broad and narrow scale could we leverage? What current changes in government policies exist? What local resources or organisations would be interested in partnering? How do the mission statement of the hospital or strategic plan align with your current aim? The threats, what obstacles do we face? What are our competitors doing? What are quality standards or specifications, our jobs, roles or services changing? Is changing technology threatening our program or notes or roles? Could any of our weaknesses seriously threaten our program? And it's really important to start thinking about that. You could have an absolutely wonderful aim at the top saying, I'm going to reduce the age of diagnosis to 3 to 6 months because, that's what I want to do in my setting, but is that realistic? So that's why going through this SWOT process is very important. So I'm going to leave that up there, and what we want you to do now is really start identifying that. So on a piece of paper, draw it in 4 sections, put strengths, weaknesses, opportunities and threats, and start seeing if you can answer some of these questions. So because this is a little tricky to read, what I'm going to do is we're going to start off at the examples here. Is that easier for everyone to read, to sort of give you a base on what might help you looking at those strengths, weaknesses, opportunities and threats? And if you need to go back to your detection handout to get specifics, it could be a very easy place for you to start.
Excusez-moi. Okay. The Hammersmith? Okay, what I might do is, while they're working on this, I'm going to pull up the website again. Okay? And I'll make sure it's I want all my updates to I want to go through that. So what we do is there's right now about there's 8 certified trainers in the U.S. We do not charge, and we do not have to, I promise you. And there's 2, but Lena and Untitled Chapter, so they told us. And we send people all over the place, and they're coming up with an international certification for trainers, so that then train trainers, so that people can just go disseminate it. But to be a trainer, they want us to meet certain criteria. It's not that hard. We just do it. We should offer. Malheureusement, la nutrition n'a pas de corps, n'est pas standardisé de la même façon que le Hammersmith. Il y a certains éléments communs, mais malheureusement, il n'y a pas de score qui permet de dire à dans la nutrition, ce score-là va produire la nutrition. C'est beaucoup plus difficile. Donc, nous, on utilise la nutrition généralement après 10 ans. Mais avant ça, c'est pour ça. Non, mais le problème, c'est que la raison pour laquelle ils ont utilisé ces choses-là, c'est que c'est les seuls examens éléments qui ont assez d'évidence et de recherche pour dire que ça peut nous aider avec la taille, etc. Donc, mais c'est très très facile si vous utilisez d'autres examens qui diront je sais faire ça, je peux apprendre ça. Vraiment, si vous faites la nutrition, apprendre le Hammersmith, ça prend un an. Donc, c'est très très difficile. Et des mouvements, oui, on utilise ça, mais c'est comme c'est très cher. C'est très cher, bon, c'est 3 jours, plus c'est presque c'est $1 000, donc à peu près 1 100 € pour aller faire certifier en German Business. Donc c'est très très cher, au moins 10 000. Et donc nous, ce qu'on fait, c'est qu'on a certaines personnes qui peuvent certifier, qui peuvent le lire, et les autres, les infirmières, par exemple, prennent des vidéos et nous les envoient. Et nous, on les lit et on leur dit tout de suite, on a des minutes. Ah oui, exactement, WhatsApp. Tu m'en parles encore? Sorry. Yeah? Health providers. How do you So we actually have a workshop after that. We have a new company. So that would be done. The parents, we might think that they're not ready, but they actually are fully capable of making their own decisions. And so if a parent is not ready, it could be that where I'm uncomfortable. The best answer, that's not them. And what research has shown is that parents want to know early, and they lose comes, the more medical providers, when they feel that we're hiding things from them. So when we think a parent is not ready, what we first do is we use the term high risk. And we assume that high risk means that there's a greater than 90% chance. And then we have them come back after we've had that, but we explain this would not be the end of the world. It's just cerebral palsy, the most common motor problem in the world. And in developing countries, it's 7 times more prevalent than here. People have long, healthy, happy lives with cerebral palsy, and they're like, but what will it mean for my child in the future? And I say, what would you like it to be? You love your child, you care about your child is going to go on. But if you want, we can talk about it. And I have them come back and I show them the neurological experience, and I show them, this is what you see how your baby is doing this, a parachute. Instead of putting both hands down, one hand goes like this. And I'm like, do you see that? And they're like, yeah. And at home, he doesn't use his left hand. And so we start the conversation with high risk, and then a few months later, I have them come back, show them the same thing, and say, okay, let's talk about the biosensor. So that's one thing. What can you do that? The health provider, that's the problem. So we have a conference every year, and same thing. We believe that this should be. I live in Columbus. We have a conference. We feed people. We have them come and it's $300 for 3 days every day. And it's all workshop based in small groups. And the providers do role playing. And they have an opportunity to hear from people like Peter Rosenbaum and other people who are telling them, okay, I pretend I'm the parent, you pretend you're the doctor. Let's go through this. And we all say, this is not comfortable. So what are we going to do about it? This is not comfortable. I mean, part of me, every time, wants to cry a little bit when I have to tell that to my family. But the other part knows it's not the end of the world. And I have so much hope for them. I do research on interventions. I know that they're going to do it. And so we teach that. It's 3 days or two days most, and it's all small group workshops. This was supposed to be a small group workshop. No, we're having trouble. Okay, y'all. Dr. Duncan's going to talk about the last part of this. And then after that, I promise you, I will pull up the website for the Hind, and anyone who wants to come and talk to us about Hind training, please come on over, okay?
Okay, so we're going to go through yet another tool that you can use in starting to figure out how you're going to implement the guidelines or pieces of the guidelines in your current setting. So we've talked about the SWOT, and now we're going to go into process mapping. And remember that the goal here today is to get you started, to introduce you to these tools so that you can continue to flesh this out as you go home and work amongst your team. So what is process mapping? It's a way to write down a process. So it makes what's happening tangible, and it puts it, because it's on paper, you can share the information and talk about it, and ensures that everyone is on the same page in how a process does or should work. The first step in improving a process is really understanding what it is. So the reason you want to write down your flow process is so that you can really understand where you are and make every change that you make tangible. So we're going to go through how to write a flow process. So the first thing that you need to understand is sort of this legend, or the key for the shapes that you will have in your flow process. So the green will be the process start. The square is a step within the process. The diamond is a decision point, and the red will be the end of the process. And having the standardized shapes really helps, again, for anyone who is looking at your process flow to really understand what you've done. So just to give you an example, a simple example, so morning coffee. So what's your process for getting morning coffee? This is how you would draw a process flow for that. So the process start is you need coffee. So then there's a decision point. So that's the yellow diamond. Do I make the coffee? Yes or no? So the decision point is always going to have the yes or no options. If yes, then you're going to then go on to measure the grounds and add water. That's a process step, the blue square. Turn the coffee maker on, pour your cup, and enjoy. And then you stop. So there's your red stop. If no, you're going to drive to the coffee shop. Order your coffee, receive your order, and enjoy. And that also takes you to the stop point. So very simple process flow for getting your morning cup of coffee. So one of the things about a process flow is it allows you to capture all the options for a decision. And you can have more than one start or stop point. That's also important to know. And you usually, in order to come up with your process, because they will generally universally be far more complicated than making your morning coffee, you need to watch the process that's going on in your institution. Talk to all of the people that are involved in the process, interviews, watch it, see how it actually goes rather than how you imagine that it goes. So could it look different? Process maps can really differ depending on who mapped it, what level of detail they want, and why you're mapping it. So if the goal of all process mapping is really to communicate how a process works. So you want to understand the process and improve it, and coming up with your process flow can help in both of those steps. So this is how this could look a little bit different. So if someone wants to make more decisions rather than just deciding they're going to make the coffee and then measuring grounds of water, you want to determine if it's decaf or regular, and you have a lot more decisions to make. And again, you can make this even more granular with more details. So going to the coffee shop, adding in getting dressed, ordering the coffee, reviewing the menu. So it really depends on who is making the process flow and the level of detail that's desired. And again, here you have one stop point, but it's often the case that you may have more than one. So this is an ideal process flow. So on the left side, you're identifying the region or area that you're focusing on. So at the top this is focused on making the guidelines or getting the guidelines to work within the institution. So what's your process in the NICU? What's the process at 3 to 4 months corrected age and at 5 to 12 months corrected age? When you start, you will likely start with just one of these. Because you are going to likely need to take this in pieces depending on what your institution and what your resources are and what the situation is. But you have your start, and you can see that we're using the same shapes, decision points from the legend that we spoke about. You have your start point, you move all the way over, and you always want to begin with the end in mind. What's the goal that you're trying to accomplish? So maybe your goal is to have more 3 to 4 month visits, because we know that that's important based on the guidelines. You need to figure out what your process is for getting the 3 to 4 month visits in now, if there's one present, and then start writing the process for improving those, if that makes sense. So now what we want to do is we want to take probably 5 to 10 minutes just to begin to draw your process flow. I'm going to go back so that you can see the legend. So just begin to draw the process flow that you currently have. So you started with your SWOT and you had an aim involved in your SWOT. So taking that aim, just starting to write out the process that you currently have to meet that aim. And we'll come around and answer any questions.
For all of you who've been asking us, how do you get people more comfortable with doing this? How do you find out about each element, how it works, how to apply it? How do I learn how to do everything from the Hammersmith to the GMA to the TIM, to some of these elements, who want much more concrete? We can't do it in an hour here. We have a conference called I3 for CP. It's an implementation conference. So it's not about all this amazing high quality research that you're seeing now. It's about how to translate that research into practice. You're more than welcome to come. The other thing is, after this, I'm going to put up this website for Dr. Cohen and the Hammersmith, okay?
What elements, out of everything you've identified, what elements do you think could you implement? Have you chosen one? Who do you think, okay, this is one, or are you going to try and do all of them?
No, we kind of were thinking about the SWOT analysis.
Y'all, I'm so sorry. This was supposed to read 2020, not 2019. It's next year, not right now. It's not next week. Thank you for pointing it out.
We did not yet finish the SWOT analysis, because what I think is that the SWOT analysis supports the steps you will take in the action plan.
It does, so, absolutely. So you can work on that more.
Yes,
yeah,
and
definitely.
there's many strengths and weaknesses that kind of relate to how people collaborate in the hospital.
100%. And so I think the piece then that you do is you can then do, okay, what's the current process? So you can now sort of start mapping it out, and then what's the ideal process? And then where are those weaknesses and strengths potentially just break that process or stop it in its tracks? And that's where you'll really be able to start to develop. So yeah, do your current one, so you sort of know that from the very beginning. So, you know, at 0, at 3 to 4 months, at 6 and 9 months, what's happening? Who's involved? And what are they doing? Okay, I was going to follow the guidelines. What would be my ideal process? You know, would I have certain people doing whatever, and then going, okay, do we have the resources and the infrastructure to make that happen? Do we have the people willing to do it? And so that's how you can bring those pieces in. And you could also just have the morning coffee one up there too, as an example. And so, yeah, as you could see, you could make them as simple as possible. So your process pretty much. So we've just brought up the website here because a lot of you are sort of asking particularly about the Hammersmith Neurological Infant Examination. And this is a website that actually got launched maybe 3 to 4 months ago, and it combines both of them. So it's the Hammersmith Neurological Infant Examination and the Hammersmith Neurological Neonatal Examinations are both on here. And so it'll give you a quick guide as to, you know, the history and background. But then one of the really helpful pieces in here has these options down the bottom. So it has videos, so it's got teaching videos that have been developed by Francis and Lena, showing you how it can be done. It has the performers and the scoring sheets of what it is, and then all the articles on the best evidence around this particular examinations. I would strongly recommend, if you're interested in learning about this examination, going to this website. So it's hammersmith-neuro-exam.com. And as I said, this is a very new website that's just been brought up in the last 3 to 4 months, and it will have all those different elements for you. Now, depending on where you are in the world, there are different trainers that can run a Hammersmith Infant Neurological Examination course between sort of a 6-hour course. Now, those courses are free, and the trainers come from all different places around the world to do that. And you can contact, obviously, Nathalie or myself through, obviously, our contacts as part of this, or you can also contact Lena or Francis, depending on where you are too. So, yeah, highly recommend having a browse of this website because there are some wonderful resources that have been placed on it.
Just so you know, there are official translations into French and Spanish and Italian. They will be posted on the site very soon so that the forms for the exam are actually, they have been officially translated, and we will post them up very soon.